I'm sure you're aware this is welcome to everyone. We're having a diverse collection of papers relating to paediatric deformity for the next 6 presentations. We'll have 5 minutes of each. Masood and I thought what we'd do is we'd have the first 3 papers run back to back, and then we'll have 7 minutes for Q&A. So if everyone can just put their questions for the first 3 papers in, then we can run through 7 minutes of chat, and then Masood can share the second half with the next 3 papers, and we'll do the same. Okay, so we'll start off with paper 182, which is, hang on, the Scoliosis Service in Northern Ireland, a blueprint for service improvement by Kieran Doherty.
Hello, my name is Kieran Doherty, and I'm here today to present the Scoliosis Service in Northern Ireland as a blueprint for service improvement. The Scoliosis Service within Northern Ireland had unfortunately become known for excessively long patient waiting lists. A quality improvement project was introduced in the hope of reducing patient waiting list times whilst ensuring that there was no compromise in surgical outcomes. To give you a little bit of background, in 2017, new patients waited approximately 9 months for initial reviews. Patients on waiting lists took approximately 2.5 to 3 years for surgery. This was in part due to only 50% of available lists being utilised and resulted in approximately 1,500 patients overdue their outpatient review appointments. Due to a series of small but significant improvements in the service, which included the introduction of pre-assessment clinics, virtual scoliosis clinics, waiting list management, and new patient mega clinics, we aimed at improving this service. The presentation today is to look at assessing whether we have succeeded in improving waiting list times, but also to assess if this has come at the compromise of surgical care. A prospective database was collected of all patients undergoing corrective surgery within our trust. We looked at an 11-month time period with 60 consecutive patients. Data was retrospectively collected from electronic care records as well as imaging modalities. We used data from 2016 and 17 as a baseline to compare against. Of the 60 identified patients, 11 were unfortunately excluded, 9 of whom were excluded because they lacked any post-operative whole spine x-rays, and 2 because they lacked any discharge documentation. From the patients identified, 15 were male and 34 were female, with a similar average age of 16. The underlying etiology of scoliosis was idiopathic in the majority of cases, with the second most common being due to neuromuscular dysfunction. Monthly cases, we performed on average between 5 and 7 cases per month over this 11-month period, with slight decreases in months around school holidays. Our corrective surgery resulted in an average improvement of 2.24 centimeters in thoracic height and a correction of approximately 26.8 degrees on Cobb's angle. Over this period, we reported a number of complications in these patients, the most common of which was anemia requiring blood transfusion, which was present in 16% of our population. This resulted in an extension of hospital admission by approximately 3.5 days. We did report that there was 3 cases of neurological deficit, 2 of which were sensory and 1 of which was motor. There was post-operative itis identified in 2 patients and chest infection in 2. 2 of our cases required return to theatre, 1 of whom for revision surgery and 1 of whom for a wound washout for a superficial infection. To compare our data with our baseline data, we almost doubled the number of cases that we performed in the similar time period. There was no difference in the improvement in thoracic height. We did, however, improve the correction of the Cobb's angle with an addition of a reduction in the number of patients requiring to return to theatre within the first month and a reduction in hospital stay. Over this time period, we've been able to reduce the new patient waits from 9 months to less than 6 weeks. The waiting list for surgery has now decreased to 9 months in children and 6 months in adults, with less than 500 patients awaiting their outpatient review. This is in part to improve utilization of the theatres, but also of the small but significant improvements that we have made into our service. We have improved the average correction of the back curvature, although and reduced our complication rates, and have slightly improved the length of stay. In conclusion, through these service changes, we've been able to maintain a high standard of care whilst improving the waiting times. Thank you very much.
Okay, so there's a few questions coming in. We'll, like I said, we'll leave them to the midpoint, but if you can keep those coming in, that'd be great. The second presentation is the effectiveness of ultrasonic bone scalpel pontiostiotomy in posterior correction of Lenke type 1 adolescent idiopathic scoliosis. And the presenter is Ali Shetawi, and I'll just press play.
Good afternoon, everybody. Thank you very much for giving this opportunity. My name is Ali Shetawi. I'm from Queen's Medical Center, Nottingham, in the UK. I will present the effectiveness of ultrasonic bone scalpel pontiostiotomy in posterior correction of Lenke type 1 adolescent idiopathic scoliosis. I have no disclosure. Partial fascictomies with pedicle screw instrumentation is widespread and well-described technique for achieving posterior correction of scoliosis. The use of ultrasonic bone scalpel described by Newton et al. For posterior column release in AS was described in 2014, and Newton concluded that there's significant blood loss reduction when he used the ultrasonic bone scalpel compared to the normal traditional osteotomy technique. Aim of the study is to assess the effectiveness of ultrasonic bone scalpel in achieving posterior correction type 1 AS as compared to partial fascictomies. Methods: retrospective review of 40 patients type 1 AS posterior correction scoliosis between 2010 and 16. Group A, consecutive 20 patients had partial fascictomies at that time. Group B had ultrasonic bone scalpel was adopted by a senior surgeon. Comparison of pre and post-operative radiographic parameters and operative data in both groups. Match for demographic parameters. Minimum of 2 years follow-up. Mann-Whitney test was used for statistical analysis. Results as shown here. Between two groups, there was no statistical significance in regard of age, sex, pre-op, major curve, cobangle, bending, major curve, cobangle, and flexibility index between two groups. However, there's statistical significant result in the post-op major curve cobangle. It's 9.87 compared to 21.9 in the fascictomy group. The percentage also of correction is more in bone scalpel group, 84 compared to 63 in the fascictomy group, and this correction maintained in 2 years in the bone scalpel group, but a little bit lost in the fascictomy group. And also there's a significant difference in post operative apical rotation, and the number of levels involved is more in favor of bone scalpel. And there is no significant difference in blood loss as described earlier by Newton and the surgical time between the two groups. The technique, as I will show in a video, you can see a craniocaudal view of the patient. The surgeons who use two-hand technique. The bone scalpel is primed with a high flow of saline for irrigation. So the surgeon starts from the right side, release, then going to midline to the left side. Then he will use his hand to make sure that's nearly release of this cut. Then we'll jack this by an osteotome. Then our limitation of this study is ultrasonic bone scalpel produce a complete posterior release as compared to the traditional fascicectomies. And also, as shown before, that ultrasonic bone group had more level corrected. So there might be a confounding factor for this. However, better correction we achieved with this, better maintenance of correction with bone scalpel. Also, there's no increase in monitoring alert, bleeding, and surgical timing. We concluded that the use of ultrasonic bone scalpel for posterior release provides more effective correction than coronal and axial plane than traditional partial fascicectomies in type 1 AS. Thank you very much indeed.
Okay, that concludes the second talk. If we can move on. So the third talk is 283, which is index radiographic measurements and the prediction of progressive in infantile idiopathic scoliosis, a comparative analysis and description of a novel predictive model. So the presenter is Adam Lloyd.
Good afternoon, ladies and gentlemen. My name is Adam Lloyd, an orthopaedic registrar on the Birmingham programme. It is a pleasure, on behalf of my fellow authors, to present this work entitled Index Radiographic Measurements in the Prediction of Progression in Infantile Idiopathic Scoliosis, a comparative analysis and description of a novel predictive model. I have no conflicts of interest relevant to the work to disclose, and at the time of recording, I am pleased to report that for those interested, this full work will soon be available as an online first article in the European Spine Journal. For those familiar with treating this population of patients, prognosis in IIS accords two possible outcomes, and it is important to be able to differentiate progressive from resolving deformities, as untreated progressive IIS is one of the few non-malignant fatal conditions in orthopedics. However, in early descriptions of the condition, by the likes of Reinder Harenstein and Jip James, differentiating characteristics between the two forms were often elusive. It wasn't until the work of Min Mehta in 1972, with her description of the rib vertebral angle difference, that those treating IIS were afforded a prognostic tool in guiding management. Mehta's method, with an RVAD cutoff of 20 degrees, was reported to be accurate in around 80% of cases. A subsequent group, led by Jip James, also reported a convex rib vertebral angle of less than 68 degrees was similarly accurate in predicting a progressive curve. It is also widely accepted that larger curves have a tendency to progress. The aims of this work were to evaluate the comparative accuracy of the index cob angle, RVAD, and convex RVA in prediction of progression in IIS, and build a model utilizing these variables to predict progression. This would be useful in identifying those at risk of progressive deformity and instigating early management, whilst avoiding superfluous treatment of those with naturally resolving curves. The work was a retrospective analysis of a UK population of patients with IIS. Index radiological parameters were measured and outcome determined over long-term follow-up. We then used logistic regression analyses and the corresponding receiver operating characteristic curve to determine comparative accuracy of each measurement category and build a predictive model of IIS progression. We identified 85 patients over a 10-year period with a mean follow-up of 3 years from diagnosis. Statistically significant differences in the index cob angle, RVAD, and convex RVA variables were identified between progressive and resolving cases. On univariate logistic regression analyses, all three measurement categories were shown to be predictive of progression and therefore included in multivariate analyses. This graph shows the three ROC curves. For any unfamiliar with ROC analysis, a diagnostic test with 100% specificity and 100% sensitivity passes through the top left corner, and a test with no diagnostic use over chance is represented by the diagonal dotted red line. On statistical analysis of the three ROC curves, the cob angle model was found to significantly outperform the convex RVA and RVAD models. Further, as shown by a separate statistic, the Nagelkirch R-squared, which is a test of how the measure of interest explains the variability in the model data, the cob angle model again outperforms the other categories. we found that addition of the convex RVA and RVAD variables provided no further added diagnostic value over the Cobb angle model alone. A separate model statistic, the Uden index, which identifies the optimal cutoff to distinguish outcomes, corresponded to a Cobb angle of 34.5 degrees, with a sensitivity of 76.3% and specificity of 89.4%. Overall model accuracy was 81.2%. In conclusion, this study presents a novel use of logistic regression modelling in the prognosis of IIS and gives valuable statistical context to the accuracy and application of the measured radiographic indices, which has been a weakness in the previous literature. From this work, we recommend particular emphasis be placed on the index Cobb angle measurement if predicting outcomes in IIS at index presentation. Thank you, and I will now gladly take any questions.
Okay, so interesting talks, 3 with a break now for a bit of Q&A. We've got quite a few questions in, none yet in that last one, so we'll start first topic, which was the recovery program. Can I just make sure that Mr. Doherty, Mr. Shetaway and Mr. Lloyd are available for discussion?
Yeah, I'm available. Can you hear me?
Yeah. Who's that?
I'm Ali. Shetaway.
Good. That's one. Is Mr. Doherty available?
Also.
Good. Who's that? Mr. Lloyd?
That's me.
Yep, good. Mr. Doherty, sorry.
We don't have Kieran in the audience.
Right, okay. So unless anyone suggests they can offer to answer on his behalf, we'll start with the second talk then. So Mr. El-Shatawi, if you can just tell us, let me just have the questions up now. So the bone scalpel study. So there's a few questions coming in. A lot of it was around technique and how that influenced your outcomes. So a sort of amalgamation of a lot of questions is, do you think that the bone scalpel allows you more extensive resection with more control and not rely on blunt osteotomies? So would you like to just give us your opinion on that?
Yeah, I think using bone scalpel is I think a good tool allowing the surgeon to have a complete release of the posterior elements. And I agree that doing like quantitative osteotomies with bone scalpel, definitely achieving more release and possible control of the curve compared to the partial fascicectomy. And it's evidence starting from 2014 when Newton described, and his colleague, the use of the ultrasonic bone scalpel, and he concluded that it decreased blood loss with 30 to 40% of his cohort, and subsequently there are many evidence support that. And the last evidence randomized trial by by Colorado, which I think we might see the results, and this is the primary goal for them, is to prove that it has less blood loss. That's one thing. Now, I think also you can achieve more posterior release, and you also allow your control cutting of your inner cortex of the bone, and this, I think, allow more correction of the curve. So that's one thing. And also we noticed that despite that our cohort and study did not show a lot of evidence about blood loss, but we think that blood loss also is a significant factor playing with ultrasonic bone scalpel.
So I suppose just an extension to the question was, do you think the bone scalpel was the tool that aided your better correction, or do you think you could have achieved the same outcomes had you used any other device but with a more extensive and wide resection?
Well, I think bone scalpel has an effect, okay, because I think you can do your release, okay, more effectively, and I think this is operator dependent. Okay, so we believe that ultrasonic bone scalpel can achieve better correction Although now we can say that using a partial, doing partial hysterectomies, okay, also is less aggressive than what we use usually with the bone scalpel. But we believe that I think bone scalpel has an effect to correct your curve.
Okay. So moving on, another question by Ashley Cole is: did you happen to look at the procedure, how it affects the SRS scores, and does that reflect the improvement in the cob angle?
To be honest, that's a good question, but I haven't looked exactly about the SRS scores. Although we follow this patient 2 years clinical down the line, but usually we follow. The main aim of this study is to see that correction, okay, effectiveness, okay, with use of bone scalpel. But that's a good point. I can have a look maybe later on.
Okay, so Mr. Lloyd, we don't have too many questions coming in for you. I've got one for you. Your assessment with these kids, all of them are pretty young. What sort of radiograph measure? Oh, sorry, what sort of standard radiograph do you use? Is it a standing, sitting, lying? How does it take it?
So there was some variability in that depending on the ages of the patients. The vast majority were a supported PA spinal radiograph in a sitting position. Okay,
thank you. And just moving on from that, the parameters that you use are all radiographic. Did you just do an isolated prediction on based on age? Do you think that has a major part?
Yeah, so we did include age actually as unpublished data as a predictor, which was found not to be significant. One of the principles of sort of logistic regression analyses is to try and keep the number of parameters that you are used as predictors relatively small. If there's temptation to just throw as many predictors as possible at the model and see what's significant. So that, and I don't know if another question that popped up in the chat about apical rotation was relevant to my talk, in which we did consider using the Nash-Moe method to look at pedicle rotation as well. But as that is certainly in our institution, a less commonly used radiographic indice in routine patient assessment, we decided not to include that either. But we may be looking at further modifying the work with inclusion of some further parameters in due course.
Okay. Masood, did you have any questions for those first three?
Yes, my question was better correction for 24% in the first paper. Was that related to earlier intervention? Because comparing the two, the group 2, you intervened earlier.
I think, Masood, that first paper, we don't have the speaker available for comments. So,
okay.
Oh, can I just ask for the second paper, Masood? It was your paper actually. It was my question that I put in the chat about rotation. How did you go about measuring rotation with regard to your correction?
To be honest with you, we extrapolated. We used two methods and tried to correlate the two together. We used the Nash-Moe for the pre-op and the Newton method post-op, because in the apical range area we had the screw. So Nash-Moe wasn't possible. Therefore, we tried to correlate the two together.
Okay. Right. Do you want to take control, Masood, or do you want me to put the presentations up?
Put the presentation up if we can continue. Yeah.
Okay. So this is Adrian Gardner presenting the long-term results of surgery for AIS, a longitudinal study using the SRS-22 outcome scores from the BSR.
Thank you. This talk is titled The Long-Term Results of Surgery for AIS, a longitudinal study using SRS-22 outcome scores from the British Spinal Registry. It is presented by Adrian Gardner, with thanks to my co-authors Ashley Cole and Ian Harding. As you're all well aware, the BSR was launched in 2012 and became mandatory in 2013. In an attempt to increase participation, a best practice tariff for recording of the details of any surgery performed was opened in 2019. In the BSR, AIS is part of the deformity pathway for those aged between 10 to 18 years, and the PROMS outcome score is the SRS-22, which is collected preoperatively and at 6 weeks, 6 months, and 1, 2, 5, 7.5, and 10 years postoperatively. The SRS-22 was first published in 1999 and consists of 22 questions with domains of function, pain, mental health, self-image, and then the total score. The aims of this study were 1, to analyse the outcomes of AIS surgery in the UK, 2, to analyse the use of the SRS-22 on the BSR for AIS surgery in the UK, and 3, to assess the BSR as a PROMS data collection tool. Permission to access the anonymised data was given by BAS and the BSS in May 2020. All of the data were subsetted to the diagnostic codes of AIS and for primary surgery. Analysis was performed over time for the completeness of the data and for the diagnoses that were also recorded in this group. There was 16,996 SRS-22 scores on the BSR. 3,860 had a diagnostic code of AIS. Of note, there were 9,917 with no diagnoses recorded, 557 labelled as syndromic, 345 with cerebral palsy, and 36 with Duchenne. Here is a composite box and whisker plot for the function subdomain. As it can be seen, function drops at 6 weeks post-surgery and then improves again back to normal at 12 months. Pain is worse at 6 weeks, but is better than pre-op by 6 months. Mental health slowly improves over time following surgery. Surgery makes a real difference in self-image, and that's seen at 6 weeks and continues to improve over time. And as a total score, surgery improves the outcome as measured using the SRS-22. However, there are issues of data completeness. Of all scores registered as potential, only 55% had a preoperative score, 39% a 6-week score, 37% a 6-month score, 35% a 1-year score, and 25% a 2-year score. In conclusion, primary AIS surgery in the UK improves the SRS-22 score across all domains, particularly self-image. However, the SRS-22 is being used to record the outcome in patients who are not AIS, likely because there is not a PROMS score for those other diagnoses. And consequently, the question is, does the BSR need different outcome scores for different diagnoses? Also, data collection is poor. Consequently, does PROMS data now need to be made part of the best practice tariff to improve the data that is on the registry? Thank you.
Sorry, apologise. So next paper is 396, the Alder Hey experience of 44 patients treated with magnetically controlled growing rods in the treatment of early onset scoliosis with a mean follow-up of 4.1 years. Presenter Ahmed Abdalal.
Good afternoon. My name is Ahmed Abdalal, and I'm presenting the Alder Hey experience with the magnetic control growing rods in the treatment of early onset scoliosis. This was a project that I was involved in during my fellowship in Alder Hey Hospital last year. So as a bit of a background, growing rod system remain the main treatment options for early onset scoliosis. Traditional growing rods require repeated lengthening procedures, which lead to increased risk of complications and also increased stiffness of the spine. This led to the emergence of magnetic control growing rods to negate these problems. However, the magnetic rods themselves came up with their own set of problems, which we'll talk about later. Our aims and objectives was to examine the ability of the magnetic rods to correct the deformity while maintaining the spinal growth, examine the complication profiles of the magnetic rods, identify risk factors that are associated with higher risk of complications, and examine the association between the mechanical failure and the clinical picture of the patients. And finally, examine the graduates from the magnetic rods at the time of the final fusion. So we did a retrospective review of the patients that were performed in Alder Hey Hospital between 2012 and 2018. 44 patients were included with a mean follow-up of 4 years with a minimum of 2 years. 41 were primary cases and 3 revisions. 38 received dual rods, while the first 6 cases were receiving 6 single rods. Number of distractions per patient was around 11. We found that the magnetic rods were able to correct the deformity significantly while maintaining the spinal growth to near normal parameters, and all the figures were statistically significant. We looked at the graduates, and there were 9 of them who received definitive fusion at an average of 3.3 years post-index procedure. Proximal and distal fusion levels were the same as the proximal and distal foundation levels for the magnetic rods. This graph shows the amount of deformity correction at various points of these 9 children. And if we look at the last bit of the graph, we find that the spine remained flexible, allowing for extraspinal deformity correction at the time of the final fusion. This was about 40 degrees, about 14 degrees. And it's worth mentioning that there was no osteotomies needed here, apart from simple facetectomies. 10 children had 18 complications between them, requiring 21 unplanned operations. This is a breakdown of all the complications that we encountered. And if we look here, we'll find that 3 of these complications were mechanical failure of the magnetic mechanism. We also found that single rods and previous revision surgery were associated with higher risk of developing a complication. We looked at our revisions. 21 children had 34 revision procedures. These were either for a complication, as previously mentioned, but some of these growing rods reached their maximum distraction ability and they needed to be exchanged for longer ones. And some children were revised to go for definitive fusion at the end of their treatment. We found 10 incidents that were specifically related to the extension mechanism of the growing rods. But as previously mentioned, only 3 of them needed revision at that time. We also noticed that 8 children had metal debris staining of their soft tissues. 4 of these 8 were associated with a complication. If we include all of these figures into our complication rate, the rate becomes 34%. So we found that the magnetic rods were able to correct the deformity while maintaining the spinal growth. And these results were consistent with other published case series in the literature. The spine remained flexible at the graduation. Unlike the traditional growing rods, there were acceptable complication rate of 23 to 34%. Implant failure and metal debris remain a significant issue with magnetic rods. Strength of our study was that it was one of the largest published case series with the longest follow-up. We also give a glimpse on the end of the treatment journey for those who received the final fusion. Limitations of our study is the retrospective nature of it and the fact that we include various diagnoses and etiologies of the early onset scoliosis, but this is with all cases of this nature. We also did a report on the sagittal balance. However, we felt that the effect of any distraction-based system on the sagittal balance is well reported and understood, so there was nothing for us to add. And these are some references.
Okay, thank you. Now moving on to the final talk of this session, which is a comparison in patient-reported outcomes in patients undergoing anterior or posterior correction of scoliosis, paper 412, presented by Hafsa Abdullahi.
Good afternoon. My name is Hafsa Abdullahi and I'm a final year medical student from St. George's University. And today I'll be presenting our project titled A Comparison in Patient-Reported Outcomes in Patients Undergoing Anterior-Posterior Correction of Scoliosis. Scoliosis surgery is a significant procedure that can be associated with severe morbidity. Although scoliosis surgical outcomes are usually evaluated via validated questionnaires, oftentimes these do not cover patients' expectations, reflecting their real-life needs, which is why we conducted a study to assess the return times to school and physical education as indirect markers of recovery in different types of anterior and posterior scoliosis surgery. We hope that the results from this study can help guide future consultations with patients and provide more accurate estimations of their recovery. So our aim was to determine the recovery time for patients with adolescent idiopathic scoliosis who underwent anterior and posterior spinal fusion. Methods. We first identified patients within our database who underwent scoliosis surgery from 2018 to 2019, with an exclusion criteria of non-AIS patients and those over the age of 18 at the time of surgery. We then administered a validated post-operative questionnaire to this cohort, which was taken from this paper here by Sarahi et al. Titled, When Do Patients Return to Physical Activities and Athletics After Scoliosis Surgery, which was conducted in 2018. The questions patients had to answer included return to school and physical education as mentioned, and also return to different daily activities such as carrying a backpack, bending, running, jogging, and riding a bike. And optionally, for patients who participated in sports prior to surgery, they could report the return times to those as well. So 100 scoliosis patients were identified between 2018 and 2019, and 19 of which were excluded via our criteria. 81 patients were then contacted and 43 responded to the survey, with a mean age of 16. We then subcategorized our cohort into 5 main surgical groups, which were selective anterior thoracic fusion, thoracolumbar fusion, and short and long posterior spinal fusion, with a 5th group being those who underwent 2-stage procedures. So on to the results. This first graph shows the return to school times reported by each patient group. Patients were able to report their return times within either 1 to 3 months, 4 to 6 months, or 7 to 12 months. And as you can see, the majority of patients within each group returned to school within 1 to 3 months. Moving on, we found similar results between the anterior and posterior groups for return to PE, carrying a backpack, bending, running and jogging. Next, we also identified patients who underwent costoplasty within each group and also looked at the average length of stay in hospital and ICU. So overall, as we said before, across all the groups, the majority of patients returned to school within 1 to 3 months. The results also showed that over time, the selective anterior thoracic fusion and short posterior spinal fusion groups had similar outcomes in return to school, physical education, and daily activities. Currently, short posterior fusions are the gold standard. However, these results have shown that selective anterior thoracic fusion can still achieve good outcomes with the added benefit of fewer fusion levels and a smaller scar for the patient. So, limitations. As the data collection was retrospective, it relied on the patient's memory of their recovery and their exact return times to different activities. And furthermore, the questionnaire format is not time specific to the exact return times for each individual patient, as they had to answer in a range of 3 months. And lastly, with the COVID-19 pandemic, the quarantine and school lockdown that was imposed in March 2020 has had an impact on the accuracy of return times reported by some of the patients. So in conclusion, we found that anterior and posterior fusions had similar return times to school, physical education, and daily activities. We also found that costoplasty did not actually affect return time to school and PE. And finally, we think that further research assessing the benefits of shorter fusions should be conducted in the future. Thank you for listening.
Okay, Masood, over to you. I think you might need to unmute your mic, Masood. I don't hear you. I don't know whether everyone else can. Does everyone hear Masood? Is it just me?
No, I can't hear Neil. I think you might have to take over.
Try one more time, Masood. No, we're seeing you. We see your face, we see your lips moving, but we don't hear you talk. I'll tell you what. I'll crack on, Masood. If you want to cut in, feel free. As soon as you get your voice back. Okay, so we'll try and run through them in order. The first one was Adrian Gardner's. So, Adrian, you got a lot of positive comments about a great study. The main issue, isn't it, is long-term follow-up. How do you think we're going to address all of that? And I think there may be a financial incentive for it, but where's that going to come from?
I think the 10-year follow-up has been put on by retrospective. I think we have to collect better data and we have to make it something that is financial. Best practice tariff has helped with operative procedures, and it has to be the same for outcome scores. Otherwise, we're not going to get robust data. And the answer is money. And that's how that comes from, I don't know. And the only way you can do it is to take it away from people and give it back, I suppose, which is a bit punitive.
Rajat Verma asked, do you have a Rottweil admin person who's available to chase up the outcomes for the next 10 years?
Yes, we do. And he was presented earlier on in a talk today, and he does very well.
Okay, over to the second paper, the magic rods. Ahmed, do you find that there's a law of diminishing returns over the course of the magic treatment?
Yes, I think I replied to that in the questions. There was, but it's a different pattern from the law of diminishing return that we noticed with the traditional rods. So with the traditional rods, there is that a very steep decline with increasing the stiffness over time. With the magic rods, we noticed that it was very gradual. So it's kind of the same pattern all over the treatment period. And I think this is consistent with the main study that was done on that by another Ahmed that is published already.
Question related to the methods of failure. Was there a difference in the failure mechanism between the pre and post 2017? I think it makes reference to the change in the construct of the design, which came on in March 2015.
Yeah, so all our cases from Alder Hey were the design used was the one that is used pre-2015. So we didn't. There was no patients that were included in that is post-2017.
Okay, and do we have Hafsa Abdullahi on the line? Yeah. Can you unmic? Hafsa, are you there? Maybe similar problems. Oh.
Hello?
Yeah, great. Okay, so I've got a question for you. Considering that AIS surgery is generally done to improve appearance and prevent progression, did the patients prefer an anterior scar or a posterior scar? That's from Rajat Verma.
Thank you for the question. I think with our questionnaire, that wasn't a question that was included. So from the data I was collecting, I'm not actually sure if the patients preferred an anterior posterior scar.
Okay, another question. Adrian Gardner asks, was there any statistical analysis of your results between the groups?
Yes, there was.
Do you want to expand? Because maybe Adrian missed it.
Oh, okay. So for return to school, we had the short posterior spinal fusion group, 78% of which returned within 1 to 3 months. And with the and so that, we found that within all the groups, there was actually the majority returned within 1 to 3 months.
Okay. I'm just looking for any last questions. So one more question for you, Hafsa. On what basis was it decided who would get what type of anterior and posterior surgery? Did the groups differ at a baseline in any way? So what made, was it surgeon preference, or was it patient preference? Was it curve type?
I'm sorry, I don't know.
Okay. Okay, that's fine.
I'm really sorry.
No, don't worry, that's fine. Okay, well, I think that we're just about out of time. 2:45 was our end spot. I don't know whether Masood, you managed to sort out your IT issues, have you? Do you want to make any comments? No. You can always give me a call and I can put them through. No, he's not coming through. Sorry, Masood. Right, okay. Well, I think that concludes the Paediatric Deformity paper session. There's a break now, is there, Helen?
Yeah, you can leave the room now and grab a coffee before the next session that starts at 3:30.
Okay, good stuff. Thank you, everyone. And thank you to all the contributors. Very good. Excellent.